The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr. David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, the costs and conundrums of clinical registries.
We don't give industry any actual patient-level data. We only do the analysis and give them the aggregated data as a report.
That's Professor Susannah Ahern, a Senior Medical Administrator and the Head of Clinical Outcomes Reporting and Research Program at Monash University. Professor Ahern is also the Monash Academic Lead for National Clinical Quality Registries, and I'm presenting her with a challenging scenario.
The aim is at a health service level for clinical quality registries to provide complementary information to what the hospital provides currently, particularly around longer-term outcomes.
In today's scenario, the Chief Executive has set up a meeting to discuss clinical quality registries. They indicate the hospital seems to be contributing to multiple registries. There is concern that the number appears to be growing with little oversight or control. They indicate that registry work seems to involve a lot of people, including specialists, receptionist staff and data entry people. Questions are posed about how much all these registries cost the hospital, and they want to know which registries are legitimate and if any of them are mandatory. The CEO also asks who receives the reports and what value there is in the hospital in being involved in this work. First, I started by asking Professor Ahern to explain what a clinical quality registry is.
Clinical quality registries are national quality improvement activities, specifically focusing on monitoring and measurement of variation in practice and outcomes. And they are currently supported by the Commission of Safety and Quality Healthcare and the Commonwealth Department of Health. They are, more specifically, a purposeful collection of data regarding a particular disease or condition that aims to inform quality improvement by providing comparative reporting back to healthcare providers. And these activities aim to provide national-level monitoring and measurement of health system outcomes, particularly regarding high-burden, high-cost diseases or procedures. But importantly, they also have many secondary uses of their data, including for research, drug and device monitoring, and to integrate with national health data frameworks. So the aim is at a health service level for clinical quality registries to provide complementary information to what the hospital provides currently, particularly around longer-term outcomes.
Let's talk about how they get started. I've seen a few where one or two enthusiastic surgeons decide they should keep data on their own patients and then enrol their colleagues, and those grow and grow. Over the last couple of years, there seems to be a lot more formal processes and control of clinical quality registry. So how do they get started, and which ones do we know are the more robust ones?
Yeah, I think that's a really good question, and I agree, given that there are quite a number. There is actually a list on the Commission's Register of Registries where there's just over 100 activities that call themselves registries that have put themselves on this list. They're not credentialed in any way at the moment, but there is a process or discussion around a process of accreditation potentially in the future for registries. So yes, many of them were established by individual clinicians. I think this is an important point, though, that they are clinician-led. So all registries have have to have clinician leadership. They also have to be supported by a large group or group of clinicians. And ultimately, if I want to set up a registry, I want to make sure that the society, this particular clinician society or college actually supports that registry. And they don't always. Sometimes I've been involved in discussions where we're suggesting to put up a registry, a clinician isn't, and the society does not yet actually support that. So, they really should have that clinical leadership. They should have that college to society leadership. And the other thing I always ask for is, do you have funding? Because there's no point in setting up an activity that's doomed to fail because it just doesn't have sufficient funding. I agree that in the past, they were really all largely done through the research paradigm. And so they've been onboarded in hospitals traditionally through the research governance unit. And they've really followed the main outputs being publications and conference presentations and academic sort of outputs. We're really seeing a change in the last 10 or so years, particularly in the last 5 or so years, where the Commission's got much more involved. They've not only got their Register of Registries, but they've just done a revision of the framework on registries. And so they're really wanting for registries to focus on that safety and quality improvement. I did a survey last year of 64 registries took part out of 110 or so. And of those, about 2/3 provide reports back to sites. So it's not 100%, and there's certainly opportunities for improvement in registries, but that's a large set of information and data that's regularly provided back to health services with the aim to improve quality and safety.
So what sort of data do these registries collect?
So the idea with registry is you identify a particular cohort so that you can compare processes of care and outcomes. So they're usually the eligible people for each registry would be those who are diagnosed with a particular condition. So I've got a registry for cystic fibrosis, for example, or those who undergo particular treatments or surgical treatments in particular. So I also have a registry around breast device implants, for example. And so the registry then collects information that may include contact details. About 2/3 of registries collect identified data on patients so that they can be contacted, particularly for patient-reported outcome data. And then as well as contact information, they collect some ideally minimum information about demographic information, so usually where they live in terms of the jurisdiction, and then information perhaps about a few key comorbidities such as, diabetes, smoking or BMI, things that are particularly relevant to those particular conditions. And then they collect key information around what good care looks like and what are the outcomes that are important, including both efficacy outcomes, so did the patient improve following their treatment, so were there particular adverse events that followed and what are the sort of rates of those adverse events at both a population level and at an individual hospital level. So they're built around measures of what good care looks like and good outcomes look like. I agree that when you get a group of clinicians in the room, they may want to collect things that are related to their particular research interest. But what usually happens in a well-run registry is you have a Delphi process where you start off with a whole list of potential items. These could be ones that other registries use or ones from clinical care standards, and you really whittle them down to what we call a minimum data set, which is items that are particularly important and feasible to collect in a good quality way. So that's the idea. The idea as well is that registry data sets are reviewed regularly, and certainly in my experience over the last 8 years, clinical practice in just about every area changes. So the data sets must adapt so that you're collecting what's relevant information for the clinicians at any point in time and going into the future.
That raises the whole issue of what's important to the doctor versus what's important to the patient. And so often there are subtle influences on outcomes. One of them is medication compliance. How do you collect information on the people rather than simply the outcomes?
That's a really good question, and certainly what we've seen is more partnering with consumers in the development of registries and their data sets. So when I started, it was quite innovative to have a consumer representative on a steering committee, for example, for a registry, and now that's standard, and in fact we usually have more, and we may have consumer reference groups as well. The survey that I did last year showed that about 50% of registries collect patient-reported outcome measures or experience measures, and that would have been about half that 5 or 6 years ago. ago. So I think we're certainly getting that consumer input in both those ways. In terms of things like medication compliance, what we can do is do things like link with PBS datasets and link with MBS datasets to confirm or to look at our what we call case ascertainment, what proportion of cases we're capturing as well. So there are things like that we can do beyond what we collect from the hospital. And then in a way, if we collect that information that the hospital doesn't have, like the patient surveys and or the linked data, and provide that back, that's actually value-added data that we provide back to hospitals.
So who maintains the registries? Some of these procedures have got hundreds of thousands of people, particularly if you track them over 10 or 15 years. Who maintains these registries, writing out to the specialists and the patients to check their progress?
Yes, so we have nearly 40 registries at the School of Public Health and Preventive Medicine, and the oldest one started back in the late 1990s. So we do have some. These are the trauma registries that were developed when the state trauma system was modified back around the late 90s. So they can go for a long time, the very successful ones. And I think this is a good point, just to diverge for a moment, is that successful registries mean they're funded, and they're only funded if it means that some stakeholder actually thinks they're getting value out of them. So, if you've got an activity that's been funded for 30 years, then there's a key stakeholder that thinks that that's a worthwhile activity. So many of them are run by universities. So as well as us, the second biggest holder of registries in Australia is SAMRI, the South Australian Health and Medical Research Institute. There's also a smaller centre at Wollongong. So they're run by academic institutes, and that's becoming particularly important, not only because of the research method rigour and getting opt-out consent and doing all the patient consent properly, but also the data security and privacy is really important. So, we've recently put multi-factor authentication on our registries, and we have to have part of an infrastructure, a data infrastructure that's got really high levels of security and privacy measures, cybersecurity, because as we know, with identified data and personal sensitive data, we just have to make sure that we have these really good systems. So the infrastructure is becoming increasingly expensive and important.
Who pays for these registries?
Registries usually have multiple sources of funding. So the three main sources of funding are government, which is the largest at about 50% in the survey that I had, and then research grants, and then industry. And I myself have benefited my registries. Not only are mine largely Commonwealth funded, but I also have smaller industry grants and occasional research grants as well to help. So the Commonwealth is really leading a national program as well. They currently fund in this program about 10 registries, and I know they fund a few more sort of as a broader part of a program. And they've just put out a call for funding for more to support new registries earlier this year. So the Commonwealth has currently got this 4-year strategy. It received its first line item in the federal budget last year. So until 2027, it's supporting a program of, maybe up to 15 or so registries. But state departments have been funding them as well. Industry funds them in terms of pharma companies and things. The best models are where there's multiple funders, so that one funder does not have sort of total control of the registry's activities, if you like. But there's a range of sources, and increasingly we're finding agencies such as the TGA or MSAC, so the Medical Services Advisory Committee, is recommending registries to be set up to monitor the novel procedures or drugs, or ones where there's sort of very high unexplained variation. And so there are sort of these associate drivers that are not necessarily funders, but they are at those government agency level, and so they're sort of supporting the case for registries as well.
A lot of the data, particularly if you say TGA at the moment, sort of ad hoc reporting, this has gone wrong or we have worries about this, whereas a registry is a much more structured process. Are we seeing a migration from the sort of ad hoc to the more structured collection?
Yes, well, certainly the TGA is one of our biggest supporters, and they've just written a risk management framework for breast devices and noted that the Australian Breast Device Registry is really the key stakeholder in that, in terms of driving that data collection. And just to say as well, they have very high community acceptability. So for the Breast Device Registry, we have less than 1% opt-out rate. So women are very keen, and we do get calls from women every week about what device do they have, because they've seen some article about some device or whatever. And certainly certainly these days, you are given device information when you have a device implanted, but that's a relatively recent initiative. And, when we talk about pelvic mesh, there are women out there who don't even know that they have pelvic mesh, let alone what type. So, to have registries, particularly for these sort of important devices where there have been really big scandals.
You said that industry supports a number of the registries. Isn't there a conflict of interest there where a device manufacturer supports a registry and finds that their lovely device doesn't work or causes issues and they may have to do a recall or...
Look, I think it's a really good issue, that one. And I have experience in working with a pharma company in relation to my CF registry, and we also work with device manufacturers and distributors in relation to the breast device registry. I think the strength of the registries as they are is they're independent. They've been set up independently of industry. And the way we manage and the way most registries manage is that if industry wants information, if anyone wants information from the registry or data or analysis or reports, they have to go through an approval process. So they put in a request. This is the process for anyone. They put in a request. And what we say for industry is we don't give industry any actual patient-level data. We only do the analysis and give them the aggregated data as a report. And, we also say what they can and can't use that information for. So we discuss a whole lot of stuff up front about what is it they want. So we won't give them information on competition and share of the market, for example. We'll say we're a safety and quality registry. If you want to look at the outcomes of your devices compared to other devices as an aggregate, like not compared to individual brands, but other devices as an aggregate, we'll be very happy to provide you with that information. And I guess so far my experience has been that that's been very positively accepted. Generally, they use it for providing information back to the TGA. And my experience so far has not been that we've found any problematic devices that have caused any concern. But the potential is there. And I guess that's the other thing. There are other registries all around the world. So if we did find problematic device, then those companies have the opportunity to look around the world and see what other sources of corroborating or conflicting information there might be about that.
So who gets the reports? Can I ask the registry if my doctor's a good doctor?
So the reports that get sent back, about 2/3 of the registries that were in this survey said that they provide reports back to health services. They generally get sent to the PI, so what we call a PI because it goes through a research framework. So that's a person, usually a clinician at a health service, who puts up their hand and said, I'll be sort of responsible for this registry and take some sort of ownership and leadership of it. In private practice, we would provide a report usually to individual clinicians of their own data. So it's usually comparative data. Here's your hospital, here's the other hospitals. Once we've got enough information, we'll say, here's, you're a quaternary hospital or you're a rural hospital. Here's compared to rural or metro or public versus private or whatever. We do, in many instances, also seek to get information about the contact details of someone at the position of like a medical director or a director of quality and safety. If you can imagine, we've got a national breast device registry with 250 participating hospitals, 600 surgeons, and trying to keep that list updated every year, including contact details for quality and safety people, is very challenging. But we do try. And what most registries still do is provide a hard copy report, but many databases have the capacity for clinicians to go in and look at their data at any time. So, for example, I just gave an update to the Commonwealth and for my cystic fibrosis registry where there's 23 sites. We know that as well as the annual site report that we give them, that about half those sites went in and fiddled and played with their own data and did various things with it as well.
What about the patients? Can I get a report on cystic fibrosis outcomes and what interventions work or don't work?
Yeah, so one of the first things that registries do is when they get the data is they start publishing annual reports. And cystic fibrosis is a great example because there has been so much improvement in cystic fibrosis outcomes in the last half a dozen years with these new CFTR modulator drugs. And we have just shown the registry has been reporting that every year in these fantastic publicly available reports. And people are now seeing that instead of having a life expectancy 10 years ago within the mid-40s, they now have a life expectancy of about 60 years of age.
Wow.
And I spoke to the CEO of Cystic Fibrosis Australia this week and said to her, what do you think the impact of our reports is having on the community with CF? And she said, the best and the biggest thing is hope. She said they see these reports. If you've just had a baby diagnosed with CF, you see these reports, you see the change over time in life expectancy, you see the reduction reduction in hospitalisations, you see the reduction in the number of visits people are needing, and also the increase in marriage, babies. That's a big one. 80 pregnancies we reported. We reported like 5 years ago. She said people are seeing that they can have a life, and it just gives them that hope. So, look, public reports are really important. We are still working on the concept of providing individualised feedback to patients about, for them to be able to go in, for example, look at their PROMs and see how their PROMs compares to others. I don't think many registries do that yet, but that's certainly something that I think we'll get better at, is reporting that feedback directly to patients.
Susannah, where do you think registries are going to go in the future? What's your vision in the next 5 to 10 years of the Australian registry scene?
Thank you. I think we've got a lot of impetus at the moment, and I guess I'm really excited by the more people that know about registries, the more requests we're getting for data and the more uses we're seeing for registry data. Again, even when cystic fibrosis, just recently that we had a request for data from one of the jurisdictions or clinician in one of the jurisdictions because they wanted to use that data to help with service planning. And certainly even in Victoria, again, the same issue was being raised about the fact that, services may amalgamate, etc. And if you want to look at particular service such as cystic fibrosis, how can the cystic fibrosis registry data in terms of where patients live across the state help you, for plan that service delivery for the future. So I'm very optimistic. I know there are challenges. We spend 80% of our time and money on managing the sort of corralling and managing the data collection, getting approvals for new hospitals through ethics and governance, and a lot of very administrative, sort of low-value activities. We are keen to continue to work individually with the hospitals, and the Commonwealth is very keen for us to do this as well, to see what we can extract from hospitals rather than require duplicate data entry. This is going to be a long-term thing. And also, I think I would love to see hospital administrators, so people such as yourself and all the RACMA community, really become very engaged with the registries and develop things like registry policies for their organisation. So when a clinician wants to get a registry approved, that it doesn't just get approved as sort of on a pile in some research, governance office sort of paperwork, but that it actually goes to, a senior clinical committee. This is a registry proposal. Are we interested in participating in this? What's the benefit going to be? When are we going to start to see the reports? And make sure that they utilise that information as much as possible rather than it continuing, as we heard in that first scenario, to sort of be something that goes on in the background. So I really would like to see, and we're doing research in that area as well. We're interviewing health services about what they would like in their reports, what's important and that sort of stuff. So we really need to do more of that to make the biggest impact.
It's been an extraordinary exploration of the contribution that clinical quality registries make to health in Australia. So often our hospital data is episodic. You see the patient from admission, you've lost them at discharge and you don't know what happened, whereas registries take the whole life impact of that intervention on the person and track it out for many years often, providing the health service with extraordinarily valuable information on the procedures that we undertake. Thank you very much, Susannah, for your time in this podcast.
Thank you very much, David. Pleasure.
That was Professor Susannah Ahern, the Head of Clinical Outcomes Reporting and Research Program at Monash University. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.